So eventually everyone is going to see you. Oh, there you are again. Okay. I'm going to take a new picture of you, Keith, myself. Okay. And because we need that. All right. So you ready to go with your next presentation? And
I
then,
am.
Mm-hmm, and then, hey, Magic, we can get that on here too, so that way I can see. Okay, Keith, the floor is yours, sir.
Okay. Thank you again, Joe. Okay. So there we go. Again, my disclosures. So this part of the talk is going to be more on the physiology of fluid volume management. So as you can see in this picture, you have circulation and you have lymphatics. And of course, we have, two circulations. We have systemic circulation and a pulmonary circulation. So around the body to all the organ systems. And of course, where the volume goes and under what pressure, everything is hydrokinetic. So from arteries to veins, they're very similar, except that the veins have semilunar valves and the arteries have more of smooth muscle, a thicker smooth muscle that can contract. So this is the epicenter of fluid balance and life itself. Everything takes place right here in the capillary bed. The green there, that's the lymphatics. And of course, I don't have to explain the red and the blue. So what is microcirculation? Well, there's so much here to go through that I just want to have the slide up for a little bit. But of course, we all know it goes from arterioles to capillaries to sinusoids to venules. And that's called the thoroughfare channel. So even though blood is, going through your arteries and veins all the time, it's not all going through capillaries all the time. Sometimes the precapillary sphincters are, open, and you have blood going into the capillaries. And sometimes the precapillary sphincters are closed, and there's no blood. It goes right from an arteriole to a venule. So down towards the bottom there, as I said, there are some times when blood is diverted to other parts of your body that need it the most at a particular time. For example, when you're eating a meal, it's diverted to your, to your stomach for the digestive tract. Or you walk outside and you see a tiger and you run like crazy, the fight or flight kind of thing. And your cardiac output goes from 5 liters to 20 liters per minute. So again, the different sizes of the capillaries are the thoroughfare channel is down there at the bottom. And again, here's a better perspective of what sizes we're talking about when it gets down to the microns. So arterioles, they have the precapillary resistant vessels. They're 10 to 50 microns, and they're surrounded by smooth muscle. And that creates our SVR, our vascular tone. So it's richly innervated by both alpha-1 and alpha-2. It's a major site, as I said, for regulating the systemic vascular resistance or vascular tone. And the primary function, again, is the autoregulation of flow going in and out of the capillary beds, where you wash out the metabolites and you drop off the oxygen and the nutrients. So again, this is just a representation. Your normal SVR should be 8 to 1,300 dynes per centimeter square. The bottom left is vasoconstricted, and the bottom right is vasodilated. So what are capillaries? Well, basically, they're thin, and it's a thin wall that are composed of endothelium, a single layer thick, that are overlapping flat cells. And this is where everything takes place in the capillary bed, where again, oxygen is dropped off, CO2 is picked up, nutrients are dropped off, waste products are picked up. And again, we talked about the precapillary sphincters that allow either flow to go through or not to go through. Capillary sizes are so small that the red cells line up almost in a straight line as they go through single file. So 5 to 10 microns in diameter. And of course, you have the tonicity of fluids. So you have the osmolarity, which is the ions is the osmotic force, the proteins are the oncotic force. A hypotonic cell, cells placed in hypotonic solution swell. Isotonic, which is ideal. And then hypertonic, cells that are placed in a hypertonic solution shrink or crenate. And this is just a representation of that. You want to be isotonic, not hypertonic or not hypotonic. So albumin is really, really important. A lot of people don't seem to think it is. I think it's one of the best things. If you're going to add something to your pump, I think the most important thing you can do is add albumin to your pump. And then, of course, don't cell wash it all away at the end. Save it. Concentrate it, give it back. So normal concentrations are 3.6 to 5.2 grams per deciliter squared, and that's a colloid osmotic pressure of about 20 torr. When levels are below 3.2, it's generally considered dangerous. You got to remember that serum albumin is increased in dehydration, it's decreased in malnutrition, chronic liver failure, malabsorption, SLE, burns. The thing you really need to know here is that albumin is a function of nutrition. If you have a good nutrition, you're going to have a good albumin level. And if you don't eat or you drink more than you eat or whatever, we used to see this in the VA where people drank more than they ate. They always had a very crappy albumin level. And when they got on bypass, they sucked up volume like a sponge. So the key here is to have a good albumin level. Try to keep that colloid osmotic pressure. And again, the goal here is to keep it intravascular, not extravascular. So when third spacing is identified as a low protein level, albumin may be administered to regain fluid lost into the interstitium. When injecting intravenous 50 mLs of 25% albumin, you'll get about 175 mLs of additional fluid back into circulation within 15 minutes. So again, let's go a couple more things about albumin. It's the most abundant plasma protein. It's about 69,000 Daltons. It offers about 80% of the colloid osmotic pressure. Normal colloid osmotic, again, it's 18 to 22. Hemodilution really drops this. One of the big functions it does is it transports the sequestration of bilirubin, but also it transports fatty acids, hormones, vitamins, enzymes, drugs. Some of the big ones are warfarin, diazepine, DIG, NSAIDs, MDAS, thiopental, and many, many other drugs are all carried by albumin. So the one thing that I don't think a lot of people realize that it's an antioxidant and it's a free radical scavenger. So it inhibits endothelial cell apoptosis and influences the microcirculation by modifying the capillary permeability by protecting the glycocalyx. And we'll get into the glycocalyx a little bit more in a minute. The other thing it does is it's buffer an acid-base balance. It actually fixes the hydrogen ions. And this is one thing that people need to know. There's no maximal dose of albumin, and it has no effect on hemostasis. That's right. So when people say, oh, you've given so much, it's screwing up my coagulation. No, it doesn't. So again, fluid movement between compartments, as you might have seen this before a little earlier. It always wants to find its equal level. So if you have a high concentration of water and you have a low concentration of water, the fluid and the water want to equal themselves out across a semi-permeable membrane. And that's Starling's law as well. You have the osmotic pressure and the oncotic pressure that are fighting against the hydrostatic pressure. So here's going to be something very interesting. This is, if you look in the very middle between these sets of cells, we'll call it the capillary bed. These are single cells, single layer of cells, endothelial cells. And in between each cell is a space or a channel. In the middle, you have the vascular lumen. So you have vascular lumen on the inside, interstitial space on the outside. But this is the gatekeeper. You see those crazy hairs? That's what it's the gatekeeper, the glycocalyx. The glycocalyx is something that everybody has to get to learn to know. So as you can see, it's kind of, there are different pictures here where you have the glycocalyx and some other pictures that we'll get into where it's missing. The glycocalyx helps to keep fluid intravascularly and protect it from going extravascularly. So the endothelial glycocalyx is a gel-like layer that coats the entire inner surface of the endothelium throughout the entire vascular tree. It's less than 100 nanometers thick. It's made of negatively charged carbohydrate polymeric glycoproteins that are plasma soluble. It's produced by bacteria, epithelia, albumin, and other cells. If you think of it as a non-stick Teflon coating on the luminal endothelial surfaces, what's interesting is I think everybody in the audience has picked up a fish before, and it's got that slimy outer layer. That's like the fish's glycocalyx. If you were to scrape off that slime layer of a fish, it would not survive. It's protecting the fish. And if you slough off or scrape off, through sheer stress, the glycocalyx, you're going to have free movement, and you're also going to have white cells and platelets start to adhere to the endothelium. So again, it's very fine hair-like structures that ultimately they regulate nitric oxide release, and it helps to protect and regulate from leukocytes and platelet adherence. So it helps with the vessel wall for homeostasis and equilibrium. So here's a couple more pictures that I'm going to show you about the glycocalyx. There's one looking straight down the middle. There's another one on the right. It inhibits platelet adherence and coagulation, and it regulates inflammation by preventing the leukocytes adhering to the vessel walls. It shields the vascular walls from direct exposure to blood flow, shear stress, and shear stress. Basically, that's what you want. Shear stress is what sloughs it off. But again, it's a vascular perimeter permeability barrier. A couple of last pictures here. On the left, you have an intact glycocalyx. You can see those hairs. And on the right, you have it's missing, and you have white cells that are starting to get through the endothelium and platelets. So again, all of these set the stage for a thrombotic event as well. So the glycocalyx can get damaged from shear stress, decreasing the nitric oxide availability and oxidative stress, a leakage of macromolecules, as we said, platelets and white cells. These damaged glycocalyx areas increase permeovascular edema, leading to leakage of fluids and proteins, which causes tissue damage and loss of capillaries. Last one, the glycocalyx. Actually, I don't think it's the last one. So hypoxemia actually will also help to remove the glycocalyx. So you want to make sure you always have a minimum level. Don't get to the minimal levels of oxygenation, or that could help to degrade the glycocalyx. But it's primarily fluid shear stress that strips it off of the endothelium. And that can be from like a very tight capillary bed when they say pump off, pump on, pump off, pump on. I had a surgeon that did that all the time. You got to go slow. You can't go fast. When you go pump down, go slow. When you come back up on flow, you got to go slow. Otherwise, you're going to be shearing off the glycocalyx. Another thing would be a large white cell that was in a capillary bed. And then you did pump off and you did pump on, and it just, when it went pump on, it sheared off the glycocalyx. But whatever the stimulus is, shedding the glycocalyx leads to a drastic increase in vascular permeability. This permeability enables the passage of macromolecules and other harmful antigens, leading to third spacing edema, and organ dysfunction. So this is the last slide. And on the left, you'll see the hair-like structure, and it's what we call homeostasis or equilibrium. Everything's going well. You're not having platelets or white cells, and you're not having fluid go massively extravascularly. And on the right side, you have the abnormal. It's been sheared off. You have leaky capillary beds now, and you're starting to get platelets and plasma, white cells, to adhere into the tissue beds of the capillaries. So there's 4 types of capillary beds. We've all been taught this. You have your tight, continuous, fenestrated, and discontinuous in different parts of your body everywhere. And this is just another representation of a continuous, a fenestrated, and a discontinuous capillary bed. So how do fluid shifts happen? Well, we discussed this a little earlier, but we'll go over it just a couple more times, a couple great visuals here. So you have capillary pressure, and you have interstitial pressure. You have plasma colloidosmotic pressure, and you have interstitial fluid colloidosmotic pressure. And here's another one where you have hydrostatic pressure wanting to push fluid out, and you have osmotic pressure wanting to pull it in. So on the left side, you can see arterial end. It's under hydrostatic pressure, where it's going to push out almost everything except for the red cells in the capillary bed. And then on the capillary bed end, in the venule side, under colloidosmotic pressure, all those things are brought back in. So again, you're pushing out oxygen, or you're delivering oxygen and picking up CO2, but you're pushing out into the tissue bed all the nutrients that you need, and you're picking up all the waste. So pushed out on the arterial end under hydrostatic, pulled back in on the venule side. And this one last one is a great representation as well. So the green is the lymphatics. That's the body's natural sewer system. On the left side, you have the hydrostatic pushing the fluid out. It comes in contact with the cells of the body. And then on the right side is the venule side, or the osmotic gradient, that pulls the fluid back in. Now, what happens when you don't have a good colloid osmotic pressure? Well, normally that extra volume is taken up by the lymphatics, so the body's natural sewer system. So you may not have a good albumin level, but you're counting on the lymphatics to help pick up that extra fluid and return it back. Here's the kicker, the lymphatic system. There's a lot to read here, but what I've highlighted here is the most important thing. Lymph is not pumped through the body like blood is. It's moved predominantly by contractions and movements of skeletal muscles. So what is the one thing that every single patient has in common when they go to surgery? Mm-hmm. They're not moving. We've paralyzed them, so essentially we have paralyzed the lymphatics. Now, if you do not have a good colloid osmotic pressure and your lymphatics are not working, you're going to have organ edema and tissue edema because that fluid is not going to be able to find its way back. And again, this is the lymphatic system. If you start at the bottom, you see the capillaries. It works its way up, all the way up to the left subclavian where it's returned to circulation. The loss of protein and lymphatic flow. This is a slide from Dr. Valeri up at Naval Blood Research at Boston University. He's since passed away, but this is about 15 years ago. And he took 4 students. And he was testing them where he would plasmapherese them over a period of 8 days. And as he took off more and more proteins, their lymphatic flow increased to make the difference. Now, you and I and everybody else in the audience has lymphatics of about 2.4 liters a day. Every day, 2 to 4 liters a day is being returned by the lymphatics. But if you have a low protein, lymphatics really kick it up a notch, and they start to pick up. And as you can see, it can be up to 10 liters a day of low protein situation. So there's 4 causes of edema: obstruction, permeability, plasma protein reduction, and capillary pressure. We're going to focus on plasma protein reduction. Reduction in circulating plasma proteins, especially albumin. Remember, liver dysfunction, malnutrition, or acute alteration in fluid status, which is something that we do. Albumin attenuates the movement of fluid out of the intravascular space and into the interstitial space. And as I said to you earlier, it's the number one as far as plasma colloid osmotic pressure of all the proteins that we have. It's albumin. It's about 78 to 80%. So fluid overload is an independent predictor of mortality. And this is from that Chappell article, A Rational Approach to Perioperative Fluid Management. I would suggest everybody read that paper. It is so good. But what he showed was if you came into the hospital and you put on 10 extra pounds intraoperatively, you've increased your mortality, not morbidity, mortality by 10%. Mm-hmm. And if you increase your body weight from pre-op to post-op by between 10 and 20%, you've increased your mortality by 20%. And then anything over 20%, and again, this is not treated with diuretics or trying to get the volume off by ultrafiltration or whatever. Untreated, anything over 20% is 100% mortality rate. And that's, again, in that Chappell paper that you should definitely read. So hypoalbuminemia leads to third spacing. Worst case scenario, anasarca. Joe, you were the ones that told me about anasarca. Well, I always saw it. I didn't know it had a name until you told me about it. But basically, it's generalized edema, swelling, very low oncotic pressures. Again, levels below 3.2 albumin are considered dangerous. So, and I've already mentioned this earlier, if you give 25% albumin, 50 mLs will bring about 175 mLs back into circulation. So perfusionists have tools to minimize hemodilution. The big ones, obviously, albumin, mannitol osmotrol, Lasix, and hemoconcentrators. Those are our tools to help fluid management. So we talked about this before. The 3 types of methods of ultrafiltration, or we didn't talk about this, but I'm telling you now, there's 3 methods of ultrafiltration. The traditional muff, which requires, cannulation to stay in, prolongs OR time, requires a combination of many team members. You have to have patience, and sometimes it requires inotropic support. Then you have homemade or single pass versus multi-pass. You can try multi-pass, but most of these people that make up their own things, they can generally not get multi-pass. And then you have the Hema Bag Method. The clinical studies performed here, there is a paper that we did, homemade versus the Hema Bag, and that was the Delaney paper, which we can show some data from right now. Again, Hema Bag circuit is easy to use. It's a 2-liter bag. You fill it, you concentrate it, and you reinfuse it. Not only that, but there's no new capital equipment. You're using one of your roller heads. You're doing the Hema Bag at the end of the case, so you just use your vent pump, or if you don't have an extra pump head, just use your vent pump. So here's the results of that study when we looked at a Hema Bag method versus a homemade study. And this is when I had a lab at UConn Medical Center. And there were a couple people in the audience when I was giving a lecture and said, oh, I can do that. I can do the same thing. I get the same results. And so I said, okay, I have a lab. Let's do the Pepsi challenge. Any of you 3 or 4 or whatever you want to do, challenge me. We'll do the exact same circuits, the exact same way. We'll count the timing. We'll look at the concentration of blood, platelets, proteins, fibrinogen, albumin, and white cells. So how long did it take? And how concentrated was the blood, and then what was left in the circuit at the very end. So if you look at the extreme left, you'll see the parameters. Then you can see the Hema Bag values are in blue. The non-Hema Bag or homemade versions are in black. So if you just look at the hematocrit, the non-Hema Bag version increased the change was about 47% versus 126%, no-brainer. Platelet count 36 versus 55, no-brainer. Total protein 79 versus 178, again, no-brainer. Fibrinogen levels increased 44 or 150%, no-brainer. Albumin 80% or 114, and white cells, of course, doubled. On the right-hand side, you'll see what we did. We took 10 circuits, 5 one way and 5 another way, and each time we reduced the amount of volume at the end of the circuit. So we all started off the same volume. So A and B circuit at 500 mLs, A and B circuit at 400 mLs, A and B circuit at 300 mLs, 200 mLs, and 100 mLs. And you can see from the green on the right side, the green started off the same, but at the end, it was a much higher concentration of hemoglobin with the Hema Bag version. And at the very end, when we drained the circuits, everybody said stop, and we drained the circuits. What blood was left in the circuit? The non-Hema Bag version always had a crit of about 6, and the Hema Bag didn't have, it was negligible. And also it was much faster with the Hema Bag version as well. So here's what you can count on when you concentrate blood with a Hema Bag. You're going to get the same results almost every time, meaning a crit of about 50. So this was 500 patients done by a program out in Oregon, Salem Hospital, Specialty Care. The average they gave back was 800 mLs of 49 crit blood with a platelet count of 238 and an amazing fibrinogen count of 451 on average. Total protein of 8.2, albumin of 4.7. And when they looked at the clotting factors of 7, 9, 10, and 13, they increased on an average of 260% increase. So what is that 451 mLs or fibrinogen level? Well, if you look at it, that's about 3.7 units of FFP that you're saving that you would have discarded if you did it another way. Or you can look at it in terms of cryo. It's about 40 units of cryo. So I showed you what was in the bag when you concentrate it. Now I'm showing you what happens when you put it in the patient. So they took 12 patients and they looked at the before they gave the Hema Bag to the patient, meaning coming off bypass on the blue, and after they gave the Hema Bag, and they drew the samples 5 minutes after they had given some extra protamine, another 50 of protamine, and you can see the change. Everything was statistically improved. So again, crits were improved, platelet counts improved, fibrinogen improved, the PTT, the PT, the INR all improved. I've also gotten a whole lot of people that say, well, what's the economic, how can you prove this? So most hospitals nowadays have what is called a hospital value analysis review. So in order to get a product into a hospital, you have to prove that it's going to save them money. So this is 100 patients done at a hospital. I'm not going to tell you the name in Pennsylvania, but you can see on the top left, it says intra-op, post-op, and total. So it's RBCs, FFP, cryo, platelets. And on on average, the total was about, for each of those 50 patients, was about just over $3,000. And then you look at the Hema Bag group, the same thing, intra-op, post-op, and total. RBCs, FFP, cryo, platelets total. It was about $1,700 per patient. So it was about a $1,379 savings per case they used the Hema Bag for ultrafiltration and concentrating the end circuit volume and giving it back to the patient. So the take-home messages, there's a couple, but this is the big one. Discarding functional platelets, clotting factors, and important plasma proteins is counterintuitive to sound ethical and medical practices. It may not be viewed as negligent right now or as malpractice, but that's only a matter of time. We live in a very litigious society. It'll only take one JW patient that got blood products, and they're going to say, did you do everything you could? And they're going to say, well, we could have done this. You can see where this could potentially go. So you want to save as much autologous blood as you possibly can and not discard it. And again, on the left, you're saving red cells. On the right, you're saving everything. Is this still a good idea? Cell washers, they tend to throw out about 280 to 300 mLs per bowl of plasma. Those are the Baylors and the Latham bowl technologies. The CATS is a different story. So again, in the end here, we don't want to throw the baby out with the bathwater. We want to save as much as we possibly can. Everything that's autologous, concentrated, give it back to the patient for stability and homeostasis. Remember, those cells have every key to every lock in your body. You will not have a reaction to your own blood. You may, or you certainly will have a reaction to somebody else's blood products. 100% of the time, you get a reaction from somebody else's blood products. It may be just a little fever, or it may be a drop in your pressure, or maybe long-term, it's something really bad. And worst case scenario, it's wrong blood, multi-system organ failure, death. We talked about trolley earlier in the other presentation. That's the number one reason why people have a problem from getting blood products. So again, saving your own, you're not going to have any problems. All right, for more learning, you want to join AMSEC, you want to take the PBMS certification exam. That exam is being offered now not only for techs, meaning people that do cell washing or platelet gel or bone marrow aspirate. There's an exam for techs called the PBMT, but then there's the PBMS that separates you from everybody. Patient blood management specialist is a higher level, a blood management specialist. So be a leader in your hospital. Take that exam. It's only 100 questions. You can get that in only, there's no case requirement. You pass the exam, you get the certification. You get to renew it every other year, and it's something that you can be very proud of. You want to join the ABB, SABM, Society for the Advancement of Blood Management, and they just merged with the European version of that called Network for the Advancement of Transfusion Alternatives. But all three of those organizations, they're finely tuned international organizations solely focused on better blood management and improved care. So you want to surf the web, you want to read articles, you want to share them with other members of the cardiac team. What I've always felt, what I noticed was if I had a really good article, I put it in the pump room. I didn't ask people to read it. I just left it on the table in the pump room. Everybody ended up reading articles that were left in the pump room, including doctors and anesthesiologists that were sitting around waiting for cases. That's one of the things that perfusionists seem to all have in common. Hurry up and wait. So you get in there and you set up everything and you get all your drugs ready and your paperwork done, and then you got to wait for the mammary to come down, or you got to wait for something else. So if you got a little bit of time, leave the article out. Somebody will read it. Here's a great one. Get on the Hospital Transfusion Practices Committee and make a difference. Be the one that's for the perfusionist. Go to those monthly meetings. They usually meet just once a month. You want to find and support a champion. We talked about this earlier. Somebody who wants to change the paradigms of transfusion in your hospital's cardiac team. It can be the surgeon, perfusionist, or anesthesiologist. But I said to you before, it's got to be two of those three or it's not going to work. But you certainly would like to get also the administrator on your, as a champion. And again, you have to work as a team that's focused on improvement of patient care. There's a couple more things you can do. You want to visit these sites, noblood.org, Bloodless Medicine Research, SABM I talked about, NADA I talked about. PNBC, which is out of Canada, they've gone defunct now. There's one called the Medical Society of Blood Management, Strategic Blood Management. MyBloodFirst.com is my site, and it's an excellent site for perfusionists. They want to learn more about blood management. Also, you want to get involved. Get as many people as you can to change the paradigm of blood use. And as we've both said, you want to treat everybody like a Jehovah's Witness with a small BSA. For some reason, we can do JWs and not give them blood products, but we don't seem to take it as seriously when they're not a JW. You got to treat everybody like a JW. The bottom line is always the truth. Life is related to blood, and anything else that you can do to save more of the patient's own blood, whole blood, is better than anything else, period. Patients that get transfused with allogenic blood products are exposed to a host of new potential complications. The current data is undeniable, especially in cardiac surgery. No one is exempt from the resultant immunosuppression that people get when they get foreign blood products or allogeneic blood products. Allogeneic. The least disease, as we said, is trolley, longer delayed time to extubation and discharge from the ICU, increased risk of morbidity and mortality, both short and long term. Autologous whole blood is jugular for perfect natural homeostasis. And homeostasis means normal. We should do everything we can to conserve as much as we can of this precious substance. Remember, every drop counts. You want to avoid unneeded transfusions, save the costs, and prevent unnecessary side effects. It's in the patient's best interest, and it's the right of all patients. One of our biggest problems, especially in older docs, older perfusionists, is apathy. Don't be apathetic. Be proactive. Make the change. I've heard a lot of people say, well, it's more work, or I got a kid's soccer game I got to get to. It takes too much time. Don't be apathetic. If the data says through peer review that it's statistically better if you do something, you should be doing it. You should be trying it. You shouldn't be complaining. You shouldn't be apathetic. So I had a friend, a Jehovah's Witness friend, and great person. She said, if it's not yours, it's an organ transplant with consequences. So you want to do your best to avoid it. Remember, your decisions affect that patient for the rest of their lives. So do your best to avoid giving transfusions. Again, thank you for your time, and that's the end of this presentation.
Very good. Excellent. I think that deserves an applause, too. Very good. Okay, so I've got questions for everybody. Keith, I want to start with you. You were talking about the delivery when you transfuse saline, how so little of it stays in the circulation, that when you're transfusing the patient and you, especially massive transfusions, you're just pumping saline in to try to get the blood pressure up. What the effect of that 1 liter, you're only keeping 200 to 250, 700 to 750 going into the tissue. So think about 10 liters of circulation, if you want to talk about that at all.
Well, obviously, I think I'll get a little feedback here, Dave. I think that what happens is you get that much volume, as Chappelle says, you're in trouble. You'll be anosarchic. You'll have organ edema and organ dysfunction. And everybody knows that organs don't work well when they're edematous. So it's not just your lungs, it's every organ. It's your brain, it's your kidneys, all those things. So I would hate to have be a recipient of 10 liters of saline. Yes.
Oh, it happens all the time.
No, I know. That's why you got CRRT.
Mm-hmm. That's right. That's right. Well, how about transfuse something besides saline?
Like albumin.
It would help if you'd add some of that to it. Of course, then you need red cells. So what about you guys? I
have a question related to that. So, Keith, you did talk a lot about albumin, and I had a case where we had a trauma patient that ended up on ECMO, and our cardiac team were definitely pro-albumin on ECMO. We start giving the albumin, we start CRRT, and try to get the third spacing down. This patient was so swollen, had so much volume on board. And the trauma team, the trauma surgeons, were completely against giving albumin because they said there was already the plasma protein leakage. So if we gave more albumin, the albumin would leak, and then we wouldn't be able to get the fluid back in. And that was a big debate between the two, and they would not let us give albumin. Do you have any experience with that or any comments?
Yeah, well, you want to start early with albumin. When I say giving it on pump, I'm talking about not waiting till you're on pump. You want to start right away, because the minute you go on pump, you're starting to third space fluid. So you want to have a higher colloid osmotic pressure to stop the movement of the fluid extravascular. And then, like you said, a lot of people will say, well, it's just gone extravascular, and now that it's extravascular, it's pulling fluid more extravascular. No, that's not the case. That can potentially happen, but when you have fluid extravascular, you got to hemoconcentrate it, or you bring the fluid back in intravascular. You got to hemoconcentrate that volume off. Otherwise, it will go back extravascular. You have got to keep that movement in the right direction, which is inward, not outward. And I think that a lot of people don't understand that. I can tell you from personal experience, and I'm sure everyone on this panel has seen this. You've hemoconcentrated a liter, and the crit didn't change. Joe? You guys have seen that, right?
Absolutely.
Yes.
See it all the time.
And what's happened is your higher colloid osmotic pressure now intravascular is pulling in more fluid from the extravascular. So essentially the crit hasn't changed. You certainly have to hemoconcentrate more to get to the point where I call it the quick. So you get to a certain point where you're actually removed enough that it's going to make a big change now in your hematocrit.
That's right. Well, you have a plasma refill rate.
Right.
So the more you're hemoconcentrating the intravascular blood, then the more, or the higher the oncotic pressure, the faster in the blood, the faster will be your plasma refill rate. So that's why you see that you're ultrafiltrating, but the crit hasn't changed. In fact, your volume hasn't changed. Sometimes your volume goes up in the reservoir. I've seen that happen before too.
True.
But I will say this, and it was a good question, Keith, that Stephanie asked. The one contraindication to albumin administration is a true capillary leak. If you have a true capillary leak, then if you give albumin, it's going to exacerbate an already big problem. And generally speaking, I would say once you have a capillary leak, you're in the bottom of the ninth, you got 2 outs and no one on base, and a blind person's coming to the plate. You got a problem.
I want to say, I agree with everything you said. This particular case was not a cardiac case. It was not a bypass case. It
Probably
was a
sepsis.
trauma case.
Oh, trauma?
Well,
it was trauma?
Case. And then we ended up on ECMO after all the fluid had been given, So we didn't have the opportunity to treat it how we would in a cardiac case.
I doubt they actually had a capillary leak. I doubt they truly did, because you usually see that.
How would you know for sure?
How do you know
How would you know?
Because generally, you see it in sepsis. It would be very unusual for an otherwise healthy individual with just
septic.
Trauma. If he was septic,
He was.
Well, okay, in sepsis, then you really don't know for sure, but you can look at the clinical presentation and you're making a judgment call because you just don't know. But with that, when you have a capillary leak like that, if they are septic, the extravasation of water from your and proteins and everything else, you can't maintain a circulation. It's extremely difficult to control. And usually, like I said, it usually portends a very bad outcome. Tammy, let me talk to you about this if I can. You had mentioned in your slides that the hemoglobin if it was less than 8 or less than 7, that there was no difference in various metrics, including acute myocardial infarction or acute coronary syndrome. And I'm trying to wrap myself around this in that, hemoglobin equals oxygen transport. And so, if your hemoglobin goes down, your O2 transport, given the same cardiac output, also goes down. So you have to do something. Either you have to decrease demand, lower the temperature of the patient, or you have to increase cardiac output. So I guess I can't really understand why there was that difference.
Well, the study that I read said actually they didn't have enough data to make that determination, but that was their hypothesis, that it wasn't going to make a difference between 7 and 8. I think what they're getting at is tissue oxygenation is what your goal is. And higher hemoglobins don't necessarily correlate with that. And they were promoting in many of the studies that I read that we need to be thinking about different ways to measure tissue oxygenation. And it's not just by a higher hemoglobin. You have to look at the whole picture.
Well, that's a very good point. I mean, I would agree with that. You know, that's true. You also mentioned that there was an increase in infection rate, death, MI, et cetera, all of these bad things we don't like to see happen with patients that receive transfusions versus not. But my question, and Keith, I want you to jump in on this too, is how much of that is contributed by the sicker patients needing the transfusion?
And there was the same question.
Well, and that study actually addressed that you're not going to necessarily be able to know that for sure, but they did a lot of limiting factors where they had critically ill patients that were not transfused, and they had a statistically significant, although it's small, statistically significant differences in those. But they did acknowledge that some of that is going to be due to their comorbidities anyway.
Right. I feel like personally, I do a good job with blood management. I'm conservative about giving. So if I am giving a patient all of those products, it's because they are extremely sick or there's a huge problem in surgery, and then they're more likely to have a bad outcome, like you said.
Right.
I mean, it just makes sense.
Something I didn't mention in there because I didn't really have time to get into it, that particular study was fascinating. They actually, in one of the, actually, I think it was a different study, I'm trying to think of who it was now, had a prediction that they thought harm would be caused with infection by giving transfusions too much. And harm would be caused by not giving transfusions enough in the ischemic category. And actually, when they got through with that study, their predictions were wrong. It was harm from both of them. Obviously, you know, you're going to have to give blood when you have to give blood, but they were looking at, they really thought that the risk of ischemic events would outweigh the risk of the negative blood transfusions, but that's not what happened.
Yeah, I think that is interesting. Keith, you could weigh in on this too, I guess, because what Tammy just described, I believe, is the old adage, you're damned if you do and you're damned if you don't. So, you know, that is a thing. And, you know, since you're so heavily involved in AABB and all of these other organizations that function to only give transfusions when absolutely appropriate and not just, you know, because it makes us feel better. How do you address that?
Well, when I was racing through my slides earlier, it was like, wow, I should have said this or I should have said that.
Of course.
Do you remember when I was talking about the anesthesiologist, I said 8 to 10, no change. And that was something that was 3 different studies were done. One was done at Duke, one was done at Henry Ford, and I forget the other one now off the top of my head. But what they found after they looked at thousands of patients was that if somebody had a hemoglobin that was less than 8 and they transfused them, they actually improved. But when the hemoglobin was greater than 10 and they transfused them, they did worse. They had other problems. But between 8 and 10, it neither helped them nor hurt them. So it stands to reason that 8's the magic number. And I talked about that with the axial streaming of a crit of 24 or a hemoglobin of 8. That seems to be the sweet spot, the magic number, the place to be. If it falls below 8, you have to consider transfusing. If it stays above 8, you shouldn't even think about transfusing. And we're talking about all comers and all surgeries. Well, so that's where I...
Yeah, okay. I mean, and I don't mean to interrupt you, but I got to... Well, of course, I think you have to use every tool at your disposal. But there's just such a big difference between an otherwise healthy 50, 60-year-old having coronary surgery to a kidney dialysis patient who maybe is 69 years old and not necessarily in the best of health, to a 78-year-old, very small, almost pediatric size, frail female. And so, I don't know. I mean, I've always practiced with considering the hemoglobins that I'm comfortable with based upon the patient's physiology that I'm dealing with at the time. And, what's their body habitus like? What's their basic physiology like? And I think that individually there can be cases where a higher hemoglobin really, really matters. And I think that there can be cases where, or rather, let me rephrase that, where there's individual cases where you could get away with very low, you need really high. And then there's these statistical analyses that look at so many patients that you lose that individualization. And I think that's where practice habits come from. I don't know, what's anybody's thoughts on that?
Well, I think you make
diatribe.
A good point. And I think it's actually, it's a central point in what I think Keith and I were both leaning towards is you have to look at the big picture of your particular patient. You are going to do your best practices for them. But again, some patients are going to respond differently than others. I mean, some of them you can have a hemoglobin of 6 on pump and they look great. And others you have a hemoglobin of 7 and they are sagging. Right. And no other reason than that. Maybe they're all things being equal. You can't really figure out why.
I think it's you have to look at saturations, pressure. Lactates, base deficits.
Yeah, we don't even measure lactates. We don't measure COP anymore. Why not? I used to measure COP on every single case. I don't think you could ask for one. They wouldn't even know what you're asking for.
I don't think they would.
Well, and I think wherever we're at, everyone involved in the care of the patient has to be on the same page. I hate nothing more than working so hard on bypass, getting a crit up to 25 when if I didn't work and ride a little lower, it'd be 20. And then as soon as we come off or go to the ICU, they're like, I'll give 2 units of blood. Right. It drives me crazy.
I could just imagine. Keith, I want to talk to you about ultrafiltration.
Go for it.
So I've got a bunch of stuff. And also, well, first let me ask you this question while I formulate my question on ultrafiltration. Do you think that this thing you've taught me about, and how I just frankly never really even considered it. I mean, I might have heard about it 100 years ago, but no, in seriousness, in some basic biology book. But do you think the glycocalyx and how do you think perfusion can protect it? As perfusionists, how can we influence that? And do you think it's the new frontier of, perfusion, conduct of perfusion practice, kind of like back in the days when, we were looking at bubble oxygenators, membrane oxygenators, complement activation, nylons versus polysulfones and all that stuff that we were worried about then. Do you see this as the next new frontier first? That's question one. And then I want to talk to you about ultrafiltration. Go ahead.
Okay, so yes, the glycocalyx is the new frontier. Anything that has to do with microvascular fluid movement is now important, more important than it's ever been. So protecting the glycocalyx, there's 2 things that screw it up. One is volume loading. You have an anesthesiologist that gives lots of fluids quickly or gives boluses of fluids. That sloughs off the glycocalyx. The other is shear stress, as we talked about, pump on, pump off. So the one thing from the best paper that recently that I've read was Julie Wegner and Gerard Myers wrote a paper about the glycocalyx inject. It came out last year, I believe, and it talked about those two things: volume loading and shear forces, shear stress. And the one thing that they both came to, and Gerard and I fought for years about albumin. I was pro-albumin, he was negative albumin. But the one thing from all the literature that came out about the glycocalyx was you need albumin to protect the glycocalyx. Mm-hmm. So I'm very much a big proponent of albumin, not only because I think it keeps intravascular volume and colloid osmotic pressure, but it helps to protect the volume of the glycocalyx so the fluid's not moving out. And we talked about this a little earlier. You said that trauma patient that got 10 liters of fluid. I think that they probably volume loaded him so much that erased his glycocalyx. And now you have that big capillary leakage kind of thing going on. Again, I think you have to stay ahead of that colloid osmotic pressure one way or another to protect the glycocalyx, to keep the fluid intravascular. And of course, when you have that fluid intravascular in your reservoir, hemoconcentrated, keep the fluid moving in to the intravascular and not to the extravascular. Ultrafiltration question.
That's a very good. Okay, now this is going to be a tough one. All right.
Oh.
There's recently an article that I read, and Tammy, I need you to weigh in on this as well. And Stephanie and Rodell, I don't know if you've read the article or not, though. It's by Mongero, however you say the name, and Stammers. And in this study, which was essentially it was a retrospective chart review, I guess, of many patients. It was a big review, but they found no benefit to transfusion reduction with the use of ultrafiltration. And of course, I found that fascinating, and it didn't make sense to me. I read the paper, and I was a little bit underwhelmed with the construct of it, but I think you know more about this than I do, so I want to punt it over to you and to Tammy regarding, it goes against everything that I believe passionately. So I'm trying to figure out if we can reconcile this.
Okay, so yes, I've seen those papers. They were in Perfusion Journal, and one was in Inject, and they're controversial. First of all, they retrospectively looked at a huge database. I mean, huge database. And what they did was they used multivariable binary linear regression. So it wasn't like it was a prospective, randomized. It was definitely observational, retrospective, using multivariable linear regression models. So when you have that many patients, and I think it was over 100,000 to start, and they narrowed it down to, don't hold me to it, but they narrowed it down. You could pretty much make anything you want out of it when you're using those linear regression models. So that's number one. I think what they said was that they broke it down into 4 groups: people that got X amount of volume, then another tier of volume, and another tier of volume, and finally the highest one was 2,500 mLs of ultrafiltration or more. But the long and short of it was, everybody at that table you guys are sitting at, and everybody that I know, and every case that I ever did, if I was to hemoconcentrate because I had extra volume, it always seemed to improve the crit, unless it was that scenario where they were a mitral valve and had 10 liters on board, and no matter what I did hemoconcentrating, I had to get to that quick, where I told you get to a certain point and now you're actually improving the crit. Otherwise, you're just recruiting volume from intravascular spaces.
Or extravascular spaces.
Extravascular spaces. I'm sorry. Yeah.
Okay. Yeah, I agree with you 100%, but I do think the paper is out there, and I think that it is, of course, it's my opinion. I think it is misleading, and it concerns me because I think that ultrafiltration is such a benefit to so many patients. And I'm curious, of course, now your opinion about this paper that's out. I don't know if you've read it or not.
I haven't.
But what do you think about, Rodell, you've been kind of quiet. What do you think of ultrafiltration? I know you work with some surgeons who don't like it, don't want to use it. But they don't like it because they think it stops urine output.
It stops urine output and it inhibits the renal function, which I don't agree with. But, like Keith said, we're trying to get rid of extravascular fluid. I mean, that's my main goal. I mean, I'm not going to have 3 liters in my reservoir that the patient doesn't need.
Mm-hmm.
Well, especially when you put a liter there yourself from cardioplegia.
From
Exactly.
Cardioplegia. We use Delnido, and that is asanguineous cardioplegia.
Mm-hmm.
So I want to get rid of that after the fact.
Mm-hmm.
After we've
Well, you have the pump prime, you have the Delnido, you have pore fluid. They suck out the chest when you don't want them to. There's all these confounding factors
on top
that anesthesia's pouring
Right.
fluid in, and it's all just fluid.
Right.
The only ones giving albumin in that room is us.
So I asked the surgeon then, that doesn't like, I said, I really want to hemoconcentrate this patient or we're going to have to give blood. And he said, yeah, concentrate it at the end. So I'm like, I don't understand. Why would I wait to the end? And I'm like already opening it up. And he said, yeah, with the cell saver, concentrate
my God.
the red cells. And,
There's
and then I
nothing
looked at
better
him.
than a surgeon who knows the pump.
Right.
So then he's like, well, I mean, do what you want.
Exactly.
So I do what I wanted. But
Yeah.
Well, and I had that same scenario too.
That's not hemoconcentrating.
Right. I had a hematocrit of 20, and it was going to be one of those things. We were going to have to give blood.
Mhm.
I had already done everything I could do,
That's
and I could already see that there's what they're sucking up and all of that. Next thing you know, I'm going to have a hematocrit of 17.
Mm-hmm.
And had that same discussion, and I said, I'm not going to do big volume shifts. I'm going to take off the cardioplegia and try to take off the prime, but nothing more.
That's pretty much what I said too.
And
I'm just taking the extra volume that I
right.
gave.
I'm not trying to change. I'm only trying to change what I added. That's it.
Mm-hmm. Very good. So in addition to that, now one last thing I need to ask is, on your Jehovah's Witnesses, everybody says treat everybody like a Jehovah's Witness, all
That's
right?
the thing now.
Sure.
Treat everybody like a Jehovah's Witness. Okay. We don't operate on Jehovah's Witnesses who are coming to the operating room with a hemoglobin of 7.8.
Agreed.
That's true. They
I do
won't
think,
do it.
right.
They're
do
optimized.
Think,
Well, I think that's the point. We should be optimizing all non-emergent cases.
Yes.
Agreed.
But again, I think somebody coming to the operating room with a hemoglobin of 7.8 that we're probably not going to ultrafiltrate much because they've already diuresed the patient and they're desiccated. See, that's the thing. These anti ultrafiltration advocates don't recognize that we don't ultrafiltrate patients who don't have extra fluid to take off.
Right.
And if you did that, it's bad. We all agree with that. But we don't operate on Jehovah's Witnesses that are that haven't been given EPO for a period of time, tuned up, they're well nourished. They're usually our healthiest of patients.
That's a great point.
So, what do you think, Keith?
I think again, you want to treat everybody like a JW with a small BSA. 8 is the magic number. You should never give people blood, meaning red cells, if their hemoglobin is 8. That's the magic number. There's more and more restrictive versus liberal studies that show that's the magic number.
Mm-hmm.
So that's sort of where I'm at about all this.
Well,
okay.
I think on those patients, we have to do what we can, minimizing our circuit as much as possible, doing something I know you hate, doing wrapping and those sorts of things.
Oh, don't
I
wrap.
love it.
You brought it
I
up.
love it.
Wrap. Wrapping is the
biggest
worst
proponent.
thing ever in the world. The worst.
But
Worst.
Can someone
I'm gonna
call?
keep doing it.
Where's
should I
the
just
phone
should
number?
I
Where's
throw
the
it out
phone
there and
number?
do
Someone to call
prescriptive
in.
Oh my
oxygenators?
God, that's even
No, we
worse.
can't do that.
Oh my God.
No.
Okay, this is deteriorating.
Yes.
Keith, is he still there?
Yeah.
I really enjoyed your talk, and I'd always heard about the Hema Bag, and I never actually used it. And I just wondered if you could give us an estimated, how much time does it take when you come off to concentrate that down and give back?
Okay,
How many
so
minutes? you know?
So in minutes, it's 8 to 10 minutes
Okay.
before you're giving anesthesia a concentrated whole blood bag back. Remember, it's the same hemo bag. You fill, you concentrate, and you reinfuse from. So what you do is before you come off bypass, you give the field a 1/4 3/8 connector and a piece of discard suction tubing, like Cell Saver suction tubing,
Right.
a sterile one. They put the 1/4 inch into one of those blue or white ends of that, and they keep it on the field. They give you the other blue or white end, and you put it on top of the hemo bag, so that when they come off and they take the cannula out, they only remove the cannula, they make one connection in the field, and now you control everything. So you're able to chase the whole circuit right into the hemo bag in front of your face, and you're watching your circuit get clean as you're chasing. So when you see that line coming into the hemo bag start to clean up or look like Kool-Aid, stop. So you're only adding more fluid. You don't want to do that. You want to do it quick. So from the time you fill that, from the time you start filling that hemo bag and chemo concentrating to the time you give it back to anesthesia is 8 to 10 minutes. It's very quick.
Have you had any issues if the ACTs were a little low coming off and then you're hemoconcentrating? No clot issues or anything like that?
No, I always say to everybody, first of all, I trained in Boston where we kept the ACTs 250 with a closed coded system, heparin coded system.
All righty.
And then,
Okay.
And then they ended up, last time I heard they were up to 300 because the heparin changed and things changed.
It did change.
But even in Brigham is 350 now. You know, a lot of the places in Boston are trying to go a little lower with closed coded system. Remember, closed coded, meaning no cardiotomy.
Right.
If you're doing it, if you got to do a valve, you got to need a cardiotomy. Now you got to raise it up a little higher.
Right.
No air.
Right. Then there's the air to blood interface. But yeah, it's the interesting part. If you have, I know you haven't been able to get an opportunity to try it, but there are videos on the website and on YouTube that are 2-3 minutes long and show you how to do it from start to finish.
Well, I'm glad you brought it up. I've actually used 4 of them.
You have?
I have. I've known Keith for a very long time. So I have used 4 of them and probably would have kept using them had I stayed in that place, but we didn't. We came here. But I do think this is a product that maybe we should be discussing.
I loved that he challenged people because you always hear that, oh, that's easy. I can make something.
Yes.
So he challenged people try to do better than this. I loved that you did that.
Yes, I think, you know, and you bring up, I mean, it goes to what I believe, which is I believe, as Keith does, that the Cell Saver is a good tool. It's overused. The Impella is a good tool. It's overused. ECMO is a good tool. It's at times overused and misused. Transfusions are a good tool, but they can be misused or ill-used or overused or whatever. You know, and I think that giving the pump blood back versus going to the Cell Saver, I think has good utility, but it really does not have good utility for the acuity of patients that we're dealing with. You know, 80% of the time, otherwise healthy person, you throw a little bit of plasma away, it's not going to make a hill of beans for them. But if we're going to treat everybody like a Jehovah's Witness, if we're going to have this philosophy that we're going to do all we can to preserve that patient's blood is not only red blood cells. And so I think, Keith, to your point, you may be getting a couple of customers. I think we might be trialing it up here or something like that. If we could talk to hospitals